exam. So I'm gonna go over a couple of things. Dr. Lopata is running a little late. She's kind of the main person doing the review. Lopata and Dr. Bernstein asked me, for me to not do the review so they could do the review. So I said, fine. That's their part of the lecture. That's great. No problem with that. So while we're waiting for Dr. Lopata, I'm just gonna go over some stuff that I think is really important. So please pay attention to this. I think you guys made a lot of mistake on this on our last exam. So let me share my screen if I could see. Here you go right here. Can you guys see what that's not it. It's not this one, not this one. Jeez, not that one. Let me just share the entire screen. Share everything, desktop. Okay, great. Not that. Not that. Not that. Struggling here. There you go. Can you guys see this foot?
Yeah, we can see it.
Great. So a couple of things. Again, I won't take too long. Mine's going to be maybe 15 minutes, but I think it's going to be really productive. The first I want to talk to you about is that when you see a foot like this, and I know Dr. Brunson went over this, and if I ask you to do a septic workup, what is that? Anyone to save time? What's a septic workup?
Lactic acid.
A CBC with diff, a B, like a
I know what does
basic
that mean?
metabolic panel.
I know.
Source of
What does that mean?
infection. Try to find the source of infection.
Thank you. Trying to find this. That's right. So look at this foot. You know that probably the source of infection is right here on his foot. Does that mean that this patient might not be having some kind of infection somewhere else?
No.
Are you saying that when you have a foot like this, infections like this, do you think that this infection is only localized to this foot and can't be anywhere else?
No.
No, what does that mean? No what?
It could be other places as well.
Exactly. So basically, just because you know exactly where the source is coming from, when a patient is spiking fever aggressively, okay, and you don't know exactly where the source is coming from, or even if you do know and you just want to rule out other sources, okay, that's when you do septic workup. So when you go to extension, you're going to say, okay, let's do a septic workup. What does that mean? Patient comes to the gas gangrene. That means the patient could have a bacteria in the blood, okay? Patient could be septic. Patient could have endocarditis. Patient could be having abscess on your tooth that caused the foot infection, right? Patient could have Past disease, which is a TB, a TB bone infection. So a lot of stuff could lead to a patient spiking fever. So any patient that is spiking fever, even though you know exactly where the infection might be coming from, but you just wanted to rule out other sources. So a septic workup, just trying to rule out any other sources that this infection might be coming from or traveling to. So if I see a foot like this, I want to get, CBC with diff, or we get CBC with diff, 10% my better panel. I want to do blood cultures times 2, different sites, 15 minutes apart. The best time to do blood cultures when it's spike fever, right? I want to do echo to rule out endocarditis. I want to check their mouth to rule out dental abscesses. I want to do a urine culture. I want to do urinalysis to make sure they don't have UTI. I want to do a chest X-ray to make sure they're not really having a pneumonia. So that's what's called septic workup, trying to find out where this infection is coming from and where it's going to. Does that make sense? Are we good?
Yeah.
I only see one person saying something. Tatiana, what's going on with the group today? They're tired or what?
I think everybody's here. We'll get everyone to participate more, but yeah, we're on the same page.
All right, good. So any questions about septic workup? I hope you guys are fine with that. The next one I want to go over real quick is, I don't have a slide on this. If I show you this foot and I ask you, based on IDSA classification, will you say this is a mild infection, moderate infection, or severe infection? What would you say? And why?
Well, it's definitely not mild because it's greater than 2 centimeters away from the border
Oh,
of the
who's
wound.
talking? Who's talking? Let me give you credit.
Debbie,
Oh, Debbie Molabi. How you doing?
I'm good.
Good. You're perfect. Absolutely. So if it's mild infection, basically the cellulitis is pretty much what? Less than 2 centimeters, right?
Yeah. And moderate is greater than 2. But severe would indicate like if there's systemic infection, so you would need to know more information than just the photo, I think.
So when you say systemic infection, you are absolutely correct about that. Systemic toxicity. So you're talking about, do they meet the SARS criteria? Is that what you're saying?
Yes.
Thank you. God bless you. Awesome. Please don't fall for that trick. Again, all my exams, if you get 100, I'm fine with that. But again, I need you to make sure you understand this. What Debbie just did to me right now makes me so happy. Thank you so much. Less than 2 centimeters of cellulitis is mild. More than that, it's moderate. Okay. Even if you have more than that, if they do not have, you see this foot right here? If I'm telling you this patient does not meet the SARS criteria, this wound infection, okay, is moderate. But once they meet that SARS criteria and they have sepsis or whatnot, at that point, okay, that becomes a severe infection. Okay, another one that might get you on the exam when it comes to IDS classification. Okay, what is stage 1? Anyone? Stage 1? Anyone? I'll call names. I don't like doing that. I don't want to do that to you guys.
It's stage 1 of what?
What is the stage 1 of IDSA classification? Dr. Lopata went over it, right?
Which classification?
IDSA classification. Infectious disease classification.
No infection. No infection.
Did you guys go over there though? Okay, wait a minute. Okay, we got a problem. Did you guys go over that? Let me share screen and look for something. Let me see if I can find it.
I think Dr. Lapata went over it, but we weren't calling it stages. I think it might have had like another name other than stages, like grades or something.
But she did go over the Infectious Disease Society of America. This is called IDSA classification.
I think she correlated it to the PEDAS grade
Okay.
for
All right.
IDSI.
All right, it's fine. Let me just go over real quick. Just 2 seconds. I'm not gonna waste time on that. Let me share my screen again. Let me see if I can find it. Okay, can you guys see this?
Yes.
Okay, so this is the Infectious Disease Society of America classification or grading, doesn't matter. Grading classification is okay to call it either or, but they call it IDSA classification. So if they ask you what is IDSA classification, we have grade 1, grade 2, grade 3, grade 4. That was covered, I thought.
Yeah, it was. It was a quiz question.
So what's the problem?
I don't know. I didn't recognize IDSA.
Okay, I'm sorry. Okay, maybe okay, but I didn't tell you. But anyway, it means Infectious Disease Society of America, IDSA classification. So grade 1 is no infection. Grade 2 is what I was just talking about. It's a mild infection, right? And with that, you need to have less than 2 centimeters of cellulitis. If you have grade 3, which is moderate to severe, that's when you have your cellulitis more than 2 centimeters. So this is what I was trying to say. When it comes to your grade 3 and grade 4, the difference between them, you could have a severe infection, really bad infection, probes down to bone, pus coming out from everywhere. If they do not meet the SARS criteria, if there's no systemic toxicity, it's not grade 4. It's not grade 4. Okay. So it's very important that you should know that. Okay. Are we good?
Yep.
Okay. Make sure you know that. So how many cardinal signs of inflammation do you need for you to consider something infectious or it's infected?
2.
That's right, 2. Good. So anyway, so I wanted to cover that real quick. So make sure you remember the IDSA, please. Okay. All right. So usually 2 is considered, your mild, and 3 is considered your moderate, and 4 is really considered your severe, especially with the SARS. All right. So let me go to my other one. Stop sharing. So I just have some stuff I'm going to cover for Dr. Lopata. Oh, the next I wanted to cover real quick. Let me go back to this slide. This slide. If I tell you this patient is diabetic, right? And I say this patient has, let's just say, the patient has a moderate to severe infection, right? And I ask you, what empiric antibiotics will you place the patient on? Or what would you like to cover? Simple like that.
Staph, strep, and anaerobes, gram negatives.
What if I tell you this is a mild infection? What bug would you like to cover? Mild infection, diabetic, mild infection.
Staph and strep, Staph aureus.
That's right. That's right. It's very important not to forget that. This is very important. When you have an immunocompromised patient, or generally when you have any patient, when they have a mild infection, paronychia, something very mild infection, less than 2 centimeter, your grade 2 IDS classification, your mild infection, you should worry about stop strep, right? But once it gets to moderate to severe, you should still worry about stop strep. But if that patient is immunocompromised, like your diabetic patient, you should cover for polymicrobial. So cover for gram positive, gram negative, and anaerobes. Does that make sense? So an immunocompromised patient, okay, with mild infection, you cover staph strep. But once it becomes moderate to severe, you cover polymicrobial. Very important. Any questions about that? Anyone? Are we good?
Yep.
All right. So I cover mild, moderate, severe infection, IDSA, I cover that. Septic workup is covered. Oh yeah. I just listed some stuff down that I think is very important. Dr. Lopata is going to talk about in a minute. Wound care chapter. Okay. Please make sure you read the wound care chapter, please. On the on Watkins. Make sure you read that. Very important. So let me give a couple of scenarios. If I ask you what is the best imaging modality for this kind of infection, okay, I'll give you the infection in a minute. So a patient's got a diabetic foot infection. Okay. What is the best initial? Listen to what I'm saying. What's the best initial imaging modality for a diabetic patient with a mild infection?
Initial should be X-ray.
Exactly. Initial should be X-ray. Now watch this. Watch this. If I tell you you have a patient like this, okay, and you're worried about gas gangrene, what is the best imaging modality? Now watch the difference. I didn't say initial. I didn't say the next imaging modality. I just said what is the best imaging modality to rule out gas? What would you say?
CT.
Exactly. So the reason why I'm pointing that out, I want you to be careful on the exam tomorrow or in the future. If they ask you, a patient present, with this kind of foot infection, what will you do next? Well, the next one is X-ray, but that's initial. But if they ask you what is the best, okay, it's not X-ray anymore. It becomes whatever they're asking you. What if I say, okay, this patient's got an abscess in the bottom of the foot, and I'm asking you what is the best imaging modality for this?
MRI.
MRI, okay. What if I tell you this patient's got a Charcot with combination of osteomyelitis, and I'm asking you what is the best imaging modality to differentiate between Charcot and osteomyelitis? What would you say?
MRI.
MRI. What if I give you PET scan and I say pick between PET scan and MRI? Which one is better?
MRI.
Anybody else?
The PET scan, but it's more expensive.
That's right. Whoever said that, God bless you. I'm very happy. I'm not sure who you are, but thank you. Absolutely. PET scan is more sensitive, more specific in differentiating between osteomyelitis and Charcot. The biggest problem with PET scan is so damn expensive that nobody want to order it. But that's one of your best go-to imaging modality to rule out, especially when you have a combination of Charcot and osteomyelitis. But if you don't, then your next best really is your MRI. And obviously you got to do bone biopsy. Now, another thing you could use is your indium scan, with the WBC label scan. Okay, so I covered that. Let me see. What else do I have? Let's see here. Oh, if you have a patient like this and they're telling you, I'm not really sure if I've gotten tetanus shot in my life, what's the next thing you have to do for this patient?
TDAP.
You have to give immunoglobulin.
You're gonna get immunoglobulin by itself only, or what are you gonna?
Also toxoid.
Right. Good job. Let me try and find it. Let me see if I can find it for you. So I can get out of it. Let me see. Tetanus. What's my tetanus and IV? Let me just find it. Give me 1 minute. Yeah, I wasn't supposed to be here. It's just Dr. Lopata's stuff, but
I'm here.
oh, that's Lopata's. Dr. Lopata's. Okay, I'm gonna stop in a minute. Give me 1 minute. Let me share my screen again. Thank you, Dr. Lopata, for doing this. Let me share my screen. Can you guys see this?
Yeah, we can see it.
Okay. I took this verbatim, I think. I took this from the pocket podiatry, or they call it the Watkins. I took it from there. So the only time you're gonna give your immunoglobulin, the only time you're gonna give it is if the patient is not fully immunized. Okay. If they have less than 3 doses, that means they're not fully immunized. So if they're not fully immunized and they have a very dirty wound, it's gotta be a dirty wound. If they have a dirty wound, then you got to give them your immunoglobulin. Tetanus, you got to give them the vaccine and also the immunoglobulin combined together. But it's very important that they should know that the only time you give immunoglobulin is if they do not know their status at all, they've never fully been vaccinated, they haven't received all 3 doses, and they have a really bad infection, then you got to give them the immunoglobulin. So what do you consider a clean minor wound? So if you have a clean minor wound, it's just a wound that just maybe a little mild infection, not that badly infected, then you got to go through this, you got to use this right here. But if it's like moderate to severe infection, really bad infection, then you got to, use that, right here for really dirty wounds. So it's very important you remember that. So basically, when it comes to tetanus prophylaxis or giving tetanus vaccination, the first thing you have to ask yourself, write this down. The first thing is, am I dealing with a clean? Am I dealing with a dirty wound? Okay. If it's a clean or minor wound, then you're going to stay in this column right here. If it's a dirty wound, then you stay in this column right. That's the first you got to ask yourself. And the next you got to ask yourself is, okay, are you fully vaccinated? Have you received all 3 doses? If the answer is no, then guess what? You got to stay in this area. So that's the first 2 questions you got to ask yourself. And that will kind of help you a little bit to navigate where you're going to go. So quick question. Let's see who's going to get this right. If you have a patient that's got a high-risk wound, do you think that's under clean or under other wounds?
Other wounds.
Exactly. So high-risk wounds. So we know on the other wounds. So they're saying right here, immunization within the past 5 years. They're immunized within the past 5 years. What do you want to do for this patient? They're immunized within the past 5 years.
Nothing.
Let's see if you're right. Oh, did you cheat? We'll answer that question.
No, it's Cindy.
Oh, Cindy, you didn't cheat, right? You didn't. It's all about
No.
understanding material, right? So once you understand the material, again, perfect. Good job. So let's go to the next one. No immunization within the past 5 years. No immunization within the past 5 years. And it's a high risk.
Booster.
That's right. What about this? Never been immunized. Never, ever, ever.
Immunoglobulins and toxoid.
Beautiful. Dr. Lopata, what do you think? This was solid, right? Let me see. I'm almost done. Okay. Another one that's very important. Sorry, guys. I'm sorry, Dr. Lopa, almost done. Almost done. Let me just go through my stuff that's very important. I have a lot of slides. Where's my stuff? Where's my stuff? Where's my stuff? Where's my stuff? Almost done. Where are you? There you go, right here. On the exam, you're gonna get your CNS report. Okay. So what do you think this is? What kind of infection do we have here?
MRSA.
You're wrong. Why you wrong? Look at this. Resistance, 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 resistance. You're only sensitive to this. What kind
Is
of
that hospital acquired MRSA?
Thank you. That's where you answer this question. So when you go to externships or when you do your residency interviews, you can't just say MRSA. You got to be specific. CA MRSA, HA MRSA. Okay. Okay. Why is that so important? Well, the reason why that's so important is right here. I hope you guys know this already. That when it comes to your CA MRSA, basically these antibiotics would kill your CA MRSA. Bactrim, cycling, doxycycline, clindamycin. But it's HMR, so then you got to go into this area, vancomycin, daptomycin, dabobensin, odobensin, Tagesil, and your Teflora, which is your ceftaroline. Okay, so you have to know this. You have to know this. Very important. Okay, you have to know. Again, this was discussed already with Dr. Kaczynski. I'm not going to go into depth about that. I just want to make sure you guys remember that. Okay. All right. Dr. Lopata, you're gonna go over the Wi-Fi and the UT and Wagner, right?
Yes, yeah.
All right, good, excellent. So, class, quick question for you. If I say a wound probes down to bone, okay, what's that wound there when it comes to Wi-Fi classification? Is that group one, stage one, classification 1, 2, or 3? With the Wi-Fi classification. Probes down to bone.
Is it infected?
Infected, yes. What's that stage for that wound based on Wi-Fi? Is it 1, 0, 2, 3?
Is it 2?
Right, exactly. It's 2. But when it comes to your UT, if I say pros down to bone, what grade is that?
3.
Exactly. So you be careful with that. Anyway, Dr. Lopata will go over that in a minute. Next one that's very important, wound vac, right? With the wound vac, can I place a wound vac directly? Now, watch that word, directly on an exposed tendon?
No, you need to put a layer of adaptic.
Adaptic, right? But if they ask you, can a wound that's got an exposed tendon, can you place a wound vac on it? Okay, the answer is yes, right? You could, provided that you put a adaptic to cover it. Okay, so it's very important. So you should know that. So if they're not really being specific on the question, and they say, can you place a wound vac on a wound? I mean, we're not going to try to trick you, okay? But the question is, can you place a wound vac on an exposed tendon, to allow it to granulate in? The answer is yes. If you put adaptic on it, the answer is yes. You put adaptic on it. So I'm gonna just talk about that. Can you place a graft on a wound right after an IND? Let's say the patient's got a necrotizing fasciitis, debulking very well. Grossly looking at it, there's no sign of infection anymore. It looks very good, very granular. Can you place a graft on that right away, the same day?
No.
No. You deal with infection first.
Okay. Is there anything you could use, after doing IND? Is there anything you could use to kind of, help, improve the granulation tissue, even though there's still some kind of infection going on? Is there any advanced wound care you could use?
Like honey?
No.
I wound vac.
I won't back. I won't back. I won't back. I mean, the only time you don't put a wound back on a wound when you have a grossly infected wound, pus coming out, very fibrotic. You don't want to put on there. But after you do your good, the Brimont, and you've removed all the gross, infections or whatnot. It's still infected, but at least you should remove all the gross infection. Then you can place a wound back on it. The last thing I want to talk about is when it comes to melanoma, right? Basically there is something called the Clark and the Breslow class and the Breslow um, uh, 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 measurement or classification. So when it comes to the Clark, what do you use Clark for?
The depth.
Right. So for me, the way I remember it is when it comes to Clark, and I say CD, CD, Clark depth, and when it comes to your Breslow, I use the mnemonic BET, like the TV, BET, Breslow, thickness, BET, Breslow thickness. All right, so I'm gonna stop there and let Dr. Lopata take over, but I want to just say something real quick. When it comes to this exam, the exam is a combination of it's cumulative, but mainly focus on the last part. But the way it becomes cumulative is like, for example, UT classification, we're going to say a patient got an infection, a wound that pulls down the bone, and the patient pretty much had a positive Burgers test, right? Remember, Burgers test was covered in the first series of lectures on the vascular. So that's how we're combining the first part to the last part. So if I say Burgers is positive, that means patient's got a PAD, and you got to go from there in terms of finding out what's the UT classification. So basically, the exam is going to be about, I'll say, 35 to 40 questions on wound, but the wound is not really by itself. Really, it's a combination of wound and infection, combination of wound and PAD and stuff like that, combination of wound and Charcot. So it's just a combination of a lot of stuff, right? But the main focus, though, is the last part. So pretty much just focus really more on the last part of what we covered in your lecture. So one is about 35 to 40 questions. Emergency medicine and fetish foot and cardiac manifestation. Basically with Dr. Bernstein's lectures. That's about like 20 questions on the exam. Dermatology, again, this is where people fail. Dermatology and Dr. Marcus's lecture on steroid. There's about 11 questions to about 15 questions on that. So that's the breakdown of the exam. Again, focus more on the last part of the lecture series. But again, if you've mastered everything from the first series to the second series, I think you should be fine. You shouldn't have any problem. Any question from me before I log out? Let me make Dr. Lopata co-host. Any questions for me? No questions. Let me Dr. Lopata co-host. Okay, Dr. Lopata, you could log in now. I mean, you could share. Yes, exactly. Okay, good. All right, guys, good luck tomorrow. And if you have any questions, myself, Dr. Lopata, and Dr. Bernstein, we are available for you to send us questions. And good luck tomorrow.
Thank you.
Hey guys, can you hear me?
We can hear you.
Can you see the screen?
Yeah, we can see the screen.
Cool. All right, so let's start from the beginning. So what is wound bed preparation? You're dealing with a chronic wound. What does wound bed preparation entail? What does that mean?
Debridement of the wound and removal of the biofilm.
Okay, good. So you are addressing the wound bed itself, but what's the goal of wound bed preparation aside from debridement? There's a couple of factors that that go into account.
This is like the dimers and timers thing. So you're trying to like assess the wound and see how you can make it heal better and faster, and if there's anything else getting in the way of it healing.
Exactly, yeah. So you are absolutely correct. So you're using the mnemonics, and the mnemonics were developed in order to help you guys to evaluate the wound and see where exactly in the wound healing process the wound is stuck, so that you can get a chronic wound that is stuck in which phase of wound healing?
Inflammatory.
Inflammatory, exactly. Go on to the proliferative stage, and finally it can go into the reparative stage. So you want to address the impeding factors in order to get the wound to go from a chronic wound to become an acute wound and finally heal. Okay, so you mentioned the mnemonics, so you were a little bit ahead of me. So we have dimers and timers, and you have the timers mnemonic stands for tissue, inflammation, infection, moisture, edge, regeneration, and social factors. So in order to address the tissue, what do you need to do? What's wrong with the tissue in a chronic wound? How may it present?
It could be necrotic.
Fibrotic or slough. Exactly, yeah. So there could be fibrotic tissue or slough at the surface. It could be necrotic, and both of these types of tissues can serve as an impediment to formation of what type of tissue do you want in the wound bed?
Granulation.
Granulation tissue. And finally, when you have a fully granular wound, what can happen?
Epithelialization.
Exactly, epithelialization. So in order to address the fibrotic tissue, the slough, the necrotic tissue, what do you need to do?
Cleanse and debride it.
Exactly, so debride it, yeah. So what are some debridement techniques?
Mechanical.
Mechanical. Can you give me examples of mechanical debridement?
Pulse lavage.
Pulse lavage. What's pulse lavage?
You remove bacteria and debris with like liquid.
Liquid, yeah. So it could be a saline jet. So you're using a water gun. What other abrasive forms of mechanical debridement are available besides using water jets?
I think if you use a gauze,
To dry.
Removing dressing.
Yeah, so you can use a wet to dry gauze. How does that work? Tell me about that. How does wet to dry work?
You allow a wet dressing to dry on the wound, so when you peel it off, it comes off with the top layer of slough and stuff.
Yeah, exactly. So slough, the fibrotic tissue, and the necrotic tissue can come off with the dressing. But what also happens? You get the unhealthy tissue. What else comes off with it?
Healthy tissue.
Healthy tissue.
Yeah,
It's
exactly.
non-selective.
Exactly. It's non-selective debridement, just like what other form of debridement is considered to be non-selective besides mechanical?
Sharp.
Exactly. Sharp excisional debridement, you're cutting the unhealthy tissue with the healthy tissue. So what kind of patients would these two types of debridement be considered a contraindication for?
Ischemic wound. Ischemic wounds.
Patients with a
You're saying ischemic wounds or systemic wounds?
Ischemic.
Ischemic, thank you. Sorry, it was hard to hear. So ischemic wounds, exactly. So you want to really use caution in patients who have an ABI of 0.5 to about 0.6. So you have to be very careful. And patients who have ABIs of above 1.3, you also have to use caution in using sharp debridement and mechanical debridement, because what can happen?
non-healing like wound. You can create a bigger wound.
You can create a bigger wound, exactly. So you're causing tissue injury to the healthy tissue, and then it's not getting enough blood flow, it's not getting enough oxygen, and the wound is gonna become bigger at the next visit. So you really want to be careful in those patients, especially if their ABIs are falsely elevated, because you're not really getting an accurate assessment of their circulation. And especially for patients who have critical ischemia, it's a complete contraindication to use both mechanical and sharp debridement. So we talked about ischemic wounds, so that's patients who have severe PAD. What other type of wounds? Think of leg wounds. What type of wounds would also be, would these type of debridements be used with caution?
Venous and arterial ulcers.
Yeah, what's the term for that?
Mixed.
Mixed disease, yeah. So depending on the patient's level of circulation to the area, determined by ABI or other non-invasive vascular testing, you have to be very careful with using sharp and as well as mechanical debridement techniques. Okay, so we discussed using a water jet, we discussed using wet to dry. What are other options of mechanical debridement? What can you use that's readily available in the clinic setting?
Ultrasound.
Yeah, so ultrasound it's more commonly used in the operating room setting, but they do have it available in a clinic setting as well, and especially beneficial for your patients who have neuropathy. But think gauze. What can you do with the gauze? You have a wound that has slough and you want to mechanically debride it. What can you do?
Just rubbing the wound with the gauze.
Exactly, yeah. So you're lifting off the surface gunk. You may not be as effective in removing the fibrotic tissue, but you can remove some of the unhealthy tissue. And by doing so, you are also damaging the underlying granulation tissue and healthy tissue you want to keep. So think when you're trying to clean a wound bed, what are you doing with the scrub brush? Remember, the scrub brush can have bristles on it. So you are mechanically debriding. If you think back to your wound care evaluation and assessment of wounds, when you scrub the wounds, you are mechanically debriding. Okay, so we talked about mechanical debridement. We talked a little bit about sharp excisional debridement. What instruments can you use for sharp excisional debridement?
Curette.
Okay, good. So you could use a curette to get the wound down to healthy bleeding tissue. What else can you use?
Blade.
Blade. Good. So there sounds like there's a theme going on here. So you're using a sharp instrument. So can you use any instrument in the clinic? What other instruments are available to you besides blade and a curette?
Like a nail nipper.
Yeah, exactly. A nail nipper, a tissue nipper. You can use scissors. So any sharp instrumentation would be efficient and effective in getting rid of the unhealthy tissue. Now, think about inflammation and infection. How can we control that? We're talking about debridement. Can you control infection with debridement? It's a yes or no question, guys.
Yes.
Yes.
Yeah, exactly. So you can use debridement techniques, especially sharp debridement, to remove some of the infected, inflamed tissue. So that's excellent. Good. So we talked about non-selective techniques of debridement, like sharp debridement, mechanical debridement. What are some selective techniques? And what does selective mean?
Autolytic.
Good. And what can you use for autolytic debridement?
Films.
Honey.
You can use honey, yeah. So with film, if your wound doesn't have any moisture at all, would it encourage autolytic debridement?
No, you would have to add
No.
moisture.
Exactly. So you have to take into consideration what kind of a wound bed you're starting off with. So if you want to encourage autolytic debridement, especially with film or hydrocolloid, you want to add moisture and help cover that up, and then it will help to autolytically debride. We talked about honey. So honey increases the capability for your body to break down the fibrotic necrotic tissue. And then what other readily available resource do you guys have in the clinics, in inpatient setting? What can your patient do at home?
Hydrogel.
Yeah, they could use hydrogel. So a lot of clinics have that available. Our clinic doesn't have that available, but most do. What else?
Saline.
Saline.
Cadexin or iodine.
Saline, exactly. So I'll get to the cadexamer iodine in a second. So with saline, what needs to happen? What kind of dressing are you applying? We talked about wet to dry for mechanical,
Wet to wet.
wet to wet or moist to moist, exactly. So the goal of the treatment is to keep the wound bed moist. You're not allowing that wound bed to dry. Okay. So those are the autolytic debridement methods. What other types of debridement is available besides sharp debridement, besides mechanical, besides autolytic,
Enzymatic.
enzymatic? Give me an example of that.
Santal.
Santal.
So
What's another name for santal?
Collagenase.
Okay, good. What's the difference between collagenase and collagen?
Collagenase
Collagenase
breaks
is
down
collagen.
collagen.
Good, yeah. So collagenase breaks down the devitalized collagen. The collagen that has been broken down, it has been the collagen that's found in fibrotic tissue or slough. So it's effective in helping to remove that tissue. Okay, good. And what's collagen?
extracellular matrix.
Good. What is it used for? What function does it serve in a wound bed?
Decrease MMP.
Yeah, so it can help to offset the balance of matrix metalloproteases, which are responsible for keeping a wound in the chronic phase of healing. So, what else can it help encourage in the wound bed? What do we want to see more of?
Granulation tissue.
Granulation.
Exactly, yeah. So with granulation tissue, it looks red and beefy. So you want to encourage neovascularization within that wound bed to make the granulation tissue. So the collagen forms a foundation or a scaffold for that to occur. Okay, great. I don't want you guys to mix up collagen and collagenase. Every year, I have to make sure you guys understand that. Okay. So we talked about autolytic debridement, enzymatic debridement. What other form of selective debridement is available?
Biological.
Can you give me an example of biological?
Maggots.
Maggots, yeah. And what kind of wounds can maggot therapy be used for?
Necrotic.
Necrotic tissue, exactly. What else? What about wounds that don't have very good blood flow? Can you use maggot therapy for those? So with maggot therapy, the maggots are releasing enzymes similar to your own autolytic debridement, and they help to break down the tissue. So if you're not so confident in the blood flow, it can also be used to help clean a wound bed as well for ischemic wounds because it's not causing trauma to the healthy tissue. And then the maggots will eat up the lifted, devitalized tissue. Okay. So that covers the types of debridement. What about inflammation? We talked about debridement and in controlling inflammation and infection. What else can you do?
You can give protease inhibitors.
Yes, so you could do that as well, like collagen. What else? So you're seeing that the wound has some signs of inflammation. And what are signs of inflammation? How can you describe a wound that you suspect could be inflamed?
Rubor, dolor, color.
Exactly, yeah. So redness, swelling, there could be pain. So those are the symptoms of inflammation. And for infection, you need 2 out of the 5 signs of inflammation. So besides debridement, besides offsetting the proteases, you guys do this every day when you're evaluating a wound, you're scrubbing it down. So you're washing it. You can use saline to help clean the wound bed. And what is the goal of cleaning the wound? What are you trying to accomplish?
Reduce chance of infection.
Yes. And what's at the surface of all wounds that could lead to infection?
Biofilm.
Yeah, exactly. So you're trying to remove biofilm to decrease the risk of having the patient get an infection. So that's why it's important to wash it, to make sure that the patient is able to clean it in between visits. And it's also important to pick the dressing options appropriately. Now, that brings us to the next point. What about moisture? Do you want the wound to be moist or do you want it to be dry?
You want a balance?
You want about exactly. And if you have to pick one over the other, a more moist wound bed is more desirable because it's going to create an environment for the wound to progress to healing. If you have a dry wound, it's going to be more likely to form a scab, and it's going to be basically like a band-aid over the wound. You're still going to have a wound, and it's going to stop in its progression to healing. Okay. Let me go on in the slides. Okay. So I'll go on in a second. I want you guys to be able to identify the types of wound beds that you're seeing. So from far left, this one right here, how would you describe that?
Eschar.
Okay. What other term can you use to describe the wound bed besides eschar?
Necrotic.
Necrotic, yeah. So what can you do to remove that tissue?
Cross hatchet and
You
apply
score it?
Yeah, so you're mentioning how to apply Santal, right? Or collagenase. You can. What's the quickest way to get rid of this necrotic tissue?
Sharp debridement.
Sharp debridement.
Debridement, yeah. And what must you check before you initiate sharp debridement?
Blood
Blood
flow?
flow.
Blood flow, exactly, yeah. So if the patient has inadequate blood flow or it's too painful for them to tolerate a sharp debridement, then you can initiate the alternative options. And you mentioned using Santal or collagenase for enzymatic debridement. You can do that. You can have autolytic debridement with moist dressings. You can have the patient have maggot therapy for biological debridement of the wound. Okay, what about this wound? How would you describe that wound bed?
Fibrogranular.
Fibrogranular.
Yeah, so we talked about the different debridement techniques, and the fastest result would be from sharp debridement. What about this wound bed? What would you want to do for this one? Do you want to debride this tissue?
It's epithelialized a little.
Yeah, exactly. So all of this tissue right here, this is epithelialization. So the wound bed, it's on its way to healing. So do you want to debride all of this tissue?
No, they just grew it.
Exactly. So you don't want to touch this tissue. You want to preserve it. So then you're going to wash this wound because you want to clean off the biofilm and you want to pick appropriate dressing selection in order not to dry it out because you want to preserve the epithelial tissue and you want to encourage a moist wound bed. So what are some of the options? What can you apply to that wound?
Hydrogel.
Exactly. You could apply hydrogel. What else?
Hydrocolloid.
You could apply hydrocolloid. What else?
Honey.
You could apply honey. What else is available in most clinics for red beefy tissue like this?
Collagen.
Collagen, yeah, exactly. Okay, good. What about this tissue? How would you describe that?
Hypergranular.
Hypergranulation tissue. Now, what do you want to do with that tissue?
Debride it.
Debride it. Good. Do you think it's going to be able to epithelialize if you just leave it behind?
No.
Exactly. So too much of a good thing, you want granulation tissue, but in this case, too much of a good thing is a bad thing. It's going to prevent epithelialization. So you can debride that and then apply the appropriate dressing. Okay. Talked about debridement techniques. We talked about sharp debridement. So any instrument that cuts at the tissue would be considered sharp debridement. Okay, now we're on to moist wound healing. So with a moist wound bed, that helps to encourage faster healing. It's going to help to reduce your patient's pain, and it helps to decrease the production of fibrotic tissue development. And of course, autolytic debridement, because we talked about a moist wound bed encourages your own body to break down fibrotic and necrotic tissue. Okay, so what do we want to do for a wound that that has a macerated wound rim?
You want to try it?
You want to dry it, exactly. So you could apply betadine. You can also debride the tissue. You just have to be careful in how much you debride it. So what else can you do for this wound in order to help reduce the moisture? What dressing would you want to consider?
Foam.
Yeah, so foam is an option. So you want to apply absorbent dressings if the wound is draining. And then you want to consider, why is the wound draining? Is it coming from the inside of the wound? Is it infected? What type of a wound? Is it a venous leg ulceration? Is it a wound associated with lymphedema drainage? Or did the patient get the wound wet from showering and the dressings got wet? So you want to consider the etiology of the maceration and then address that. And the callus, you can see here, you debride that. You address, what do you do for a piboli?
Debride
Debride.
the edges.
What form of debridement? Would you use maggot
Sharp.
therapy? Sharp,
Sharp
exactly.
debridement.
Exactly. So you want to cut those edges. When would you not want to cut those edges?
Or vascular supply.
Exactly, yeah. So you would need to get appropriate vascular studies, vascular referral for possible intervention, and then after the intervention, have the patient undergo sharp debridement. So just like the wound bed should not be sharply debrided, so too the wound edges should not be, you should avoid sharp debridement. And then any undermining, you want to consider sharp debridement. You can use an advanced wound therapy called negative pressure wound therapy or wound vac to help with undermining edges. However, that's not always successful, so you may need to consider removing the undermining skin and tissue, because if you leave it behind, it becomes a cavity for bacteria to hide out, and the patient could develop an infection. And then we talked about epithelial migration. So anytime you see epithelialization, you want to be careful not to dry it out, and you want to make sure you prevent maceration as well. So you want to preserve that epithelial tissue. Okay, so next we have the R in our timers and dimers abbreviation, or mnemonic, and that stands for regeneration and repair of the tissue. So the reason why you use regenerative therapy is because you want to influence and improve the trajectory of the wound closure. And what can you do to decrease the pro-inflammatory cytokines that lead to fibrotic tissue and slough deposition? What can you do? How can we encourage regeneration and repair of the wound?
Debridement.
Yeah, so we do debride, but think to advanced wound therapy options. What can you
Barracks?
Yeah, exactly. So you can use hyperbaric oxygen therapy. What else can you use?
Wound vac?
You can use wound vac. Great. What else?
Grafts.
Graft, exactly. Grafting is so important because you can use grafts with stem cells. You can use grafts with extracellular matrix from animal source. Or from an allograft to encourage granulation tissue formation and eventual migration of the epithelium. So you want to use advanced wound therapy in order to help push the wound further on into the healing stages with your debridement techniques, with your washing and cleansing of the wound. You want to use these other techniques. So you can use collagen, you can use grafts, you can use an autograft. What's an autograft?
From yourself.
Exactly. So this is harvested from you, and you have two options. You can use a split thickness skin graft, and then you can use a full thickness skin graft. The problem with these is you're creating a wound with the split thickness skin graft. With the full thickness skin graft, you are closing the wound with suture, with staples, where you're harvesting the tissue, but you still created a surgical wound, and it can lead to an infection, especially if you have a patient who's diabetic, who is immunocompromised, who has comorbidities. So this is why we now have advanced wound therapy with skin substitutes and with grafting techniques in order for you to not use grafts from the patient themselves.